Hello class. In this recording we're going to continue our study of mental health concepts and issues, and we're going to focus on therapeutic approaches. Key therapeutic approaches relate to development of relationships with our clients, using therapeutic communication techniques, using the nursing process, intervening when crises occur, managing aggression and anger in our clients, recognizing and caring for the suicidal client, and being a part of the interdisciplinary team and using collaborative therapies. Key in nursing and mental health nursing is developing a therapeutic relationship. A therapeutic relationship is an interaction between two people, usually a caregiver and a care receiver, in which input from both participants contribute to the climate of healing, growth promotion, and illness prevention of the client. Conditions essential for a therapeutic relationship include rapport, trust, respect, genuineness, empathy, and so forth. And so I encourage you to study these concepts and read about them in your textbook and techniques to establish rapport, develop trust, show respect, and be genuine. Your book provides some really good examples of responses to clients using these skills, and you'll see more of this on your test. So obviously you want to be able to demonstrate some of these skills and demonstrate understanding on your test. There are key roles in the relationship between a client and a mental health nurse. Paplau describes these roles as that of being a stranger, being a resource person, a teacher, a leader, a surrogate, a technical expert, and a counselor. The relationship develops in phases, and the phases include the pre-interaction phase. This is where we obtain information from the client, from the chart, from significant others, and we examine our own feelings, fears, and anxieties about working with a particular client. The orientation phase is the introductory phase, and this is where we create an environment of trust and rapport, and so we use techniques to do that. We establish a contract for intervention with our client, we gather assessment data, and we identify the client's strengths and weaknesses. We formulate nursing diagnosis, we set mutual agreeable goals, and we develop a plan of action. And we explore feelings in both ourselves and in the client. And then the next phase is the working phase, and this is where we maintain trust and rapport. We promote clients' insight and perception of reality. We use problem-solving techniques to meet our goals. We overcome resistant behaviors, and we continually evaluate the progress toward the goals. The termination phase is the therapeutic conclusion of the relationship. It occurs when goals are obtained, a plan of action for more adaptive coping with future stressful situations have been established, and feelings about termination of the relationship are recognized and explored. So you'll note that in relationships with clients, they will progress through these phases almost naturally. We've got to be very conscientious to maintain professional boundaries with these clients. Professional boundaries concerns commonly issues such as self-disclosure, gift-giving, touch, friendship, or romantic associations. So I would caution you not to be self-disclosing with clients as you're dealing with them. Avoid giving gifts or accepting gifts from clients. Avoid inappropriate touch. And development of relationships and such, particularly even the Facebook relationships. Warning signs that indicate that professional boundaries are being blurred or broken may include favoring a client's care over another client's, wanting to care for one particular client, keeping secrets with a client, changing your dress style for caring for a particular client, sharing personal information or work concerns with the client, and again receiving gifts or continuing contact and communication even after the patient's discharged from acute care setting or stops seeing you at a clinic. The nursing process and assessing our patients is key to implementing therapeutic approaches. Obviously, we want to get a good history of our patient and conduct a thorough physical assessment. We want to look at our patient's appearance, behavior, and activity. These variables give us an impression of the patient's physical appearance, grooming, dress, posture, and eye contact. We want to look at their affect. The affect is the patient's immediate expression of emotion. Mood refers to the more sustained emotional makeup of the patient's personality. Patients display a range of affect that may be described as broad, restricted, labile, or flat. Affect is inappropriate when there's no correlation between what the patient is experiencing or describing and the emotion he or she is showing at the same time. This might be an example such as laughing or relating the recent death of a loved one. Both affect and mood can be described as dysphoric, depressed, anxious, or guilty, euphemic, which is normal, or euphoric, which is intense happiness. So those are some terms you can use to describe affect and mood. Communication, listening to spontaneous speech as the patient relates answers to open-ended questions yields much useful information, and you might discern problems in input or articulation such as a halting speech in a patient with word-finding difficulties, or rapid and pressured speech of patients who are experiencing excessive anxiety and manic behaviors. We want to look at think about their thought processes. The inability to process information correctly is part of certain problems associated with psychotic thinking. We want to look at their thought content. A patient with a mental disorder may exhibit overtly delusional thinking. That's a fixed, false belief not held by cultural peers and persisting in the face of objective, contradictory evidence. Perception is important. The patient may be experiencing hallucinations, which are false sensory perceptions without real stimuli, or illusions. These are misperceptions of real stimuli. They may have problems with insight and judgment. We want to assess the patient's understanding of their illness, ask them if he or she needs help and believes that feelings or conditions are normal. We want to estimate the patient's judgment based on his or her history or on an imaginary scenario. To elicit responses to evaluate a patient's judgment adequately, we might ask them questions such as, what would you do if you smell smoke in a crowded theater? A good response would be that they would call 911 or get help. A poor response is do nothing or light a cigarette. Stressors, assessing their stressors in their life is important. Each and every patient will have a unique set of stressors. And assess their coping and their management of stressors. The nursing process also includes diagnosis and interventions. Your textbook provides a wide range of diagnosis relative to anxiety disorders and cognitive disorders that we're going to be talking about in class. Some specific interventions that you need to be aware of and be able to practice are problem-solving interventions, problem-focused coping interventions. Problem-focused coping interventions are most commonly applied when stressors can be modified or changed or controlled. These are strategies that attempt to find solutions or improvements to the underlying stressor. Examples of problem-focusing coping strategies are a newly diagnosed patient attending a patient education seminar to learn about optimal disease management, or a caregiver gaining support through the access of community resources. And I don't have listed here emotion-focused coping strategies, but these strategies address the feelings one has as a result of the stressor. These strategies really don't work toward resolving the problem, but help to create a feeling of well-being. Examples include performing physical activity to relieve stress associated with an overwhelming work schedule, or attending a support group to discuss one's feelings. Cognitive restructuring pertains to assisting the client in gaining various perspectives relative to their situation and their stressors, and it is quite extensive in cognitive restructuring. It's used a lot with these disorders. It helps them to gain insight, and through the development of cognitive restructuring, they can then implement more adaptive strategies. Teaching our clients how to manage stress, anger, and conflict in time are also a part of the interventions we do as nurses. Teaching them skills for good communication and healthy relationships are also components of interventions we use quite often with a range of patients. Problem solving has 6 steps, and it is an adaptive coping strategy. Problem solving pertains to assisting clients with assessing the facts of the situation, formulating goals for resolution, and looking at alternatives and determining risk and benefits of alternatives, and then actually trying an alternative and evaluating if it works or not. Palliative techniques pertain to guiding the patient to laugh a little bit more, to relax a little bit more, and it can occur. We can use these techniques in a number of different ways, such as helping them visualize positive outcomes using guided imagery, assisting them with prayer or meditation, breathing exercises, changing their lifestyle, helping them to grow in areas that they're interested in growing in, and again, just the relaxation techniques. Some of these techniques, again, are not geared toward solving the problem, but more dealing with emotions. Other strategies and other ways of looking at stress and anxiety relieving strategies pertain to prevention. We can work to prevent in a number of different ways. Primary health promotion and protection. This is where we implement strategies in settings such as workplaces, schools, senior centers, community wellness centers, and these are individual interventions such as stress management techniques, stress reduction techniques, counseling, health education, behavioral lifestyle changes with a wellness focus. Family interventions can include family enhancement, social support enhancement, social network building. Community interventions, again, are wellness programs. So those are considered primary prevention strategies. Secondary and strategies pertain to early diagnosis of stress and anxiety problems. And this occurs in settings such as the primary care clinics, schools, senior centers, health fairs, and hospital settings. And these oftentimes are determined by screenings with a checklist and such. Disease screenings. These can happen also in community health centers. And then the tertiary or restoration or rehab is where we do this in clinics, hospitals, and community rehabs. And this can be in the form of physical rehabs focused on stress management, such as cardiac rehab or pulmonary rehab. Focusing on the types of stress is another way to address stress and anxiety. Types of stress include, we've talked about these already somewhat, but psychological and emotional, physiological, and behavioral. So you can look at the type of stress and focus your strategies based on these factors as well. Someone that's experiencing psychological and emotional stress as evidenced by anxiety, anger, depression, irritability, and so forth. Some interventions include cognitive behavioral skills training, meditation, and time management. Physiological indications of stress and anxiety include muscle tension, headache, stomach ache, acid reflux, tachycardia, hyperventilation, and elevated blood pressure. And some interventions aimed at physiological categories include biofeedback, muscle relaxation, therapeutic touch and massage, and exercise. And then we have behavioral categories of stress, and these are indicative of smoking are examples, overeating, substance abuse, and so we aim to work towards these by health education, smoking cessation, and counseling. Shown here are a number of classifications of drugs that we use for anxiety disorders, and we're going to talk about these a little bit more in class. I'm not going to make these a component of the recording, but you might want to study these categories and the nursing implications of these categories of drugs. Collaborative therapies. There's a wide range of collaborative therapies that we use for these disorders. We may use therapeutic groups. A group is a collection of individuals whose association is founded on shared commonalities of interests, values, norms, and purpose. Obviously, a therapeutic group is there to receive therapy. There's a lot of information about what happens in group dynamics, and I'm not going to go over all of those in this recording. but realize that with the groups there are stages of group functionings. There's the initiation or initial and orientation phase, the working phase, and the termination phase. And groups will progress through these phases as time, over time. There are interventions specifically aimed towards families. These include educating family about the disorders, assessing the family's impact on maintaining the disorder, and assisting families with methods to identify and change maladaptive coping mechanisms. Another form of therapy is Milieu therapy. The goal of Milieu therapy is to manipulate the environment so that all aspects of the hospitalization are considered therapeutic. Milieu therapy is quite extensive, and so every encounter is seen as a opportunity to use therapy. In Milieu therapy, there's a therapeutic community. The basic physiological needs are fulfilled with Milieu therapy. The physical facilities are conducive to achievement of goals. There's a democratic form of self-government that exists in Milieu therapy. Responsibilities are assigned according to clients' capabilities. A structured program of social and work-related activities is scheduled. Community and family are included in the program of therapy in an effort to facilitate discharge, and care is directed by an interdisciplinary team. And the disciplines may include psychiatrists, psychologists, social workers, nursing, occupational therapy, recreational therapists, and so forth. Cognitive therapy, I've already talked a little bit about cognitive therapy. It is highly structured and short-term, lasting 12 to 16 weeks, and it aims to address the automatic thoughts and correct maladaptive beliefs and schemas. The goal is to change these automatic thoughts with cognitive therapy. It includes education, cognitive techniques, modification of thoughts and schemas, and adaptive behaviors and interventions and strategies. Behavioral therapy is the thought that people have become what they are through learning processes and through the interaction of the environment and their genetic endowment. Behavioral approach therapy is that people the basic assumption with behavior therapy is that the problematic behavior occurs when there has been inadequate learning that can be corrected. So it focuses on various concepts associated with learning and then techniques to modify learned behaviors. You'll remember the behavioral therapist Pavlov with classical conditioning and Skinner from psychology. Techniques with behavior therapy include shaping, modeling, timeout, and systematic desensitization. And that's used with phobias. And then there is a combination of cognitive and behavior therapy. I really like this model. It's one of the most effective treatments for management of anxiety. And it pertains to looking at cognitions and then looking at the behaviors together. It involves learning new skills to manage symptoms, and it teaches new ways of thinking and behaving. An example for you will be shared on cognitive behavior in the classroom, so please be there to hear the example. I think it'll make more sense to you when you hear the example. In the interest of time, I'm going to go ahead and upload at this point and then make another recording just so you don't have quite as long a recording in this section of your lesson.